Hi, Dr. Anirban. Good evening.
Thank you for having me. I'm just
Your
trying to
voice
share
is
my.
very dim. We can't hear you.
Can you hear me now?
We can hear you, ma'am. We can hear
No,
you.
I can't hear. I don't know about others. I can't hear you properly.
No, we can hear sir properly.
Okay.
And can you see my screen
Yes, sir. Perfect.
in the proper mode? Like in
Yes,
the.
yes.
Okay. Thank you.
Yes, sir.
Yeah. Yeah, it's fine now. Thank you.
Thank you.
We'll start exactly in 2 minutes. Okay.
Sure.
Yeah.
And Shwetabam, this is like 1 hour, but I can stop a little bit early and ask, like, let people ask questions. Is that right?
Yes. So Dr. Arun is there and he'll be coordinating with you for the question and answer, which are there on the chat box.
Perfect. Thank you so much.
Welcome.
And sorry, can you see my pointer as well?
Yes, sir. Yeah, we can able to see.
Thank you.
Dr. Anirban, we'll just start.
Sure.
Well,
Do you want me to start now?
wait. I'll introduce you.
Okay.
Just
Okay.
a minute. Thank you, Dr. Anirban, for joining today. So, good evening, everyone. And it's a privilege to introduce Dr. Anirban Das. I think many of us know him already, and he was the faculty here in India. He has done his DM Pediatric Hemato-Oncology from PGI Chandigarh. And after that, he was in TNC Calcutta for some time, and he went for a fellowship in Sick Kids Children Hospital. Now, over there, he is working as a staff physician at Sick Kids Toronto, and he is also an assistant professor at the University of Toronto. His work mainly focuses on cancer predisposition syndrome, pediatric brain tumors, and the biology of DNA replication repair deficiencies syndromes. He has worked tremendously on this, and he co-leads the International Replication Repair Deficiency Consortium and has significantly contributed to advancing the precision diagnostics and immunotherapy approaches for children with replication repair deficient cancer. It's truly a privilege to hear him today, and we are going to understand more about this cancer predisposition, diagnosis, and targeted therapy, especially in the case of DNA replication repair defects today. And very warm welcome, Dr. Anirban. Thank you for joining today, and stage is yours. Thank you.
Thank you so much, Dr. Bansal, for the kind invitation and to the team here. So as Dr. Bansal kindly introduced, my name is Anirban. I treat children with brain tumors and I trained in India and now I'm working at Sick Kids. And what I want to share is that how my journey kind of began because as Dr. Bansal said that I was in TMC Kolkata and there one day in the evening, we had a patient who I got a call for in emergency to say that there is a child who was being treated by one of our colleagues for colon carcinoma and the child had seizure and supposedly brain mets. So I went in, we saw the child together with my colleague, we did MRI, etc. And then we had the biopsy. And then it turned out that that child had glioblastoma in the brain and colon cancer in the gut. So of course, that was not something that you find very commonly when you trained, because this was like in 2016 when I had just joined in TMC after completing my DM. So then we read up literature, we found the disorder called constitutional mismatch repair deficiency. Nothing was published in PISO or any of the textbooks. So I had to reach out to the people who were working, who are my mentors here, Uri Tabori and Eric Buffet. And they kind of held my hand in making the diagnosis, which was not straightforward. They helped with all the genetic sequencing, and that's how I kind of got drawn into the field of DNA replication repair deficiency and CMMRD. I know this is for trainees, so I wanted to highlight that if you have a odd patient that you can't really figure out, please feel free to reach out to people, reach out to 3, 4 people. Maybe somebody will have an answer, and that may change your career trajectory as it has happened for me. The second thing I wanted to share, I know I was supposed to do this last week, so I still have the brain cancer awareness logo here, but I couldn't, so my apologies. And that's why today, with the theme of the brain cancer month, though we are in June, I will focus mainly on the brain tumor aspects of DNA replication repair deficiency, and we'll probably not talk about the germline syndrome, the leukemia lymphomas, and the other solid tumors that happen here. So with that background, I want us to focus on the 4 main questions I want to kind of discuss today. So what is RRD, or DNA replication repair deficiency? Why do we practically need to learn about RRD? Not the fancy biology, which we kind of need to know a little bit, which I will talk about, but what practically is like impacting our daily patient care. How do we manage such patients here today? And some new brain tumor types that are still not in WHO, but will come in the future versions based on our work. So with that, I will probably start with the first question, which is, what is RRD? So before I talk about RRD, I do want to also kind of say that this is not my work alone. There is a big team in the background that works, and which I'm now privileged to co-lead. It's an international consortium of doctors and physicians from more than 50 countries. And I talked a bit about the clinical, practical aspects and the biology. But what I have learned in the past 6, 7 years is that how they're closely interlinked. And of course, we are clinicians, so we can't really go into the in-depth of the mechanisms of which gene and what works. But it is good to have conversations with the biologists, and I have Uri here as my mentor who I talk to all the time, to understand that what we learn from patients, we do need the research element, as you will see in my talk, of how important it is to analyze those patients' tumors, make them into cell lines, take them into animal models, do experiments, because then that feeds back into what we do on the clinical realm, which is like developing guidelines, doing surveillance, and doing clinical trials for patients. So this is just an introduction to our consortium before we move on to what I wanted to talk about first. So what is RRD? So in very simple terms, when the cell divides, the DNA replicates, and there are mechanisms in place to make sure that these errors don't go out of hand. There are a 4 set of mismatch repair genes you can see over here: PMS2, MSH6, MLH1, and MSH2, and a set of 2 polymerase proofreading genes. When either of these mechanisms are lost, the mismatch repair system or the polymerase proofreading system, we have cancers because there are so many mutations. And these cancers are unique because of the errors that they have. So the C becomes an A. This is called a single nucleotide variant change. And when many such SNVs, or single nucleotide variants, accumulate in the cancer, they give rise to cancers with high tumor mutational burden, or high TMB. The other kind of error that happens in DNA replication repair deficiency, or RRD, are these repeat chains of sequences that are either inserted or deleted. If that happens, of course, that protein or that gene will not function, the protein will not be produced. So these kinds of errors of chunks of segments being lost or added happen more in the redundant segments of the genome, which are called microsatellites. And this is called as microsatellite instability because of indels, meaning insertions or deletions. So in summary, RRD is a biological mechanism where the DNA repair replication mechanism is lost by loss of either mismatch repair or polymerase proofreading loss due to mutation in these genes, and that leads to cancers with high TMB and high MSI. Some of these syndromes or cancers come from a syndromic background of cancer predisposition, and I wanted to clarify of what we mean by that. So you can have germline biallelic loss of any one of the mismatch repair proteins. So this is biallelic, either homozygous, so same, or double heterozygous, so 2 different mutations from 2 different parents. If you have that, then all cells in your body have lost the mechanism of mismatch repair deficiency. So the cancer that happens in these individuals will of course have mismatch repair deficiency, but because of mismatch repair deficiency, they can get additional mutations in all other genes. And by random chance, that can also hit the polymerase proofreading pathway. So patients with CMMRD can have or will have always biallelic mismatch repair deficiency in their cancer, but can also have additional polymerase proofreading deficiency just because of random mutation accumulation that then hits one of the polymerase genes. In contrast, if a patient has polymerase proofreading deficiency, which is usually an adult syndrome, but now we see children with that as well, they can also accumulate errors and hit the mismatch repair system. So there can be cancers that have lost of both mechanisms. On the other hand, in Lynch syndrome, where in the germline there is monoallelic loss of one of the mismatch repair genes, cancers can develop which are just associations. So they are cancers that haven't lost the second allele, but more commonly in our world, we have cancers which have lost both alleles, and the cancers behave in the same way when they arise from a biallelic germline context. And similarly, these cancers can also get the second hit in polymerase. So what we are discussing is that there are many syndromes, but they all lead to a common mechanism of loss of mismatch repair function with or without polymerase, and the result is extreme TMB or MSA, as we talked in the previous slide. And these mutations kind of make these tumors immune hot and allow us to treat them in a different way. So as I was talking in CMMRD, many of the glioblastomas that we have both mismatch repair and polymerase loss, and this leads to extreme hypermutation. This is a logarithmic scale over here, and many patients have mutations more than 100 mutations per megabase. And as we all know as pediatric oncologists, pediatric cancers are usually driven by fusions and chromosomal aberrations. So these cancers in this syndrome are very different from all other pediatric cancers in terms of the mutation burden and lacking of chromosomal alterations, and much higher than many adult cancers, which are the traditional high TMB cancers in adults like lung and melanoma and others. So there is hypermutation all through, but what is important to recognize is that hypermutation can arise from different biological mechanisms. In the next two slides, I will talk a little bit about the biology because that helps us actually manage our patients. So mutational signatures are important to understand what is the reason for the hypermutation. For example, in lung cancers, smoking, or in melanoma, ultraviolet radiation on the skin can lead to mutation accumulation in those cells and can lead to hypermutation. But that is not mismatch repair deficiency or RRD. So we have what we call as mutational signatures that gives us an estimation based on the pattern of mutation of whether it's a C2T in a TCG location, that we know that this is arising from mismatch repair deficiency or polymerase proofreading deficiency or both, vis-a-vis lung and melanoma where the signatures are related to tobacco exposure or to ultraviolet rays. On the other hand, we also have some drug-induced mismatch repair deficiency. So patients with glioblastoma are treated with a drug called temozolomide that can also lead to drug-induced mismatch repair deficiency, and that has a different signature. So whenever we see in routine practice, which is rare in pediatric oncology, a tumor with hypermutation, we should ask ourselves what is the etiology of that hypermutation so that we understand and treat them differently from other patients. That was the mutation part, but as I said, these patients also have high microsatellite instability or high MSI. So here also we see that the signatures of MSI in this biology is very different from other contexts. So we have whole genome high microsatellite instability, and it is in the form of usually small insertions and deletions. So +1 or -1 loss or addition of chunks of the genome, which is different from, example, adult colon cancer, where they have large chunks of insertions and deletions at very specific loci on the genome. So if you use the adult type of tool to assess pediatric germline RRD cancers, you will often get false negatives, and we get so many consults and so many reports that classify these tumors falsely as microsatellite stable or MSS. That is because the panel that the adults use look at only 5 regions in the genome, and they are PCRs that look for high or like large insertions and deletions. Whereas for our patients, the changes are all through the genome and they are small ones, +1 or -1. So we need to have the appropriate tool as shown by the signatures of +1 and -1 here, shown here in a different format, to actually classify these tumors as MSI, because all of them are uniformly MSI if you use the appropriate tool. So this is again a learning for practical situation, that if you see or suspect such a cancer, but you see on the report that you have MSS, you should always read the bottom of the report to find out what methodology has been used and question that. So that was some understanding about the basic biology of RRD, and now I will focus on why we as practicing pediatric oncologists or training pediatric oncologists need to learn about RRD. So one is that it is not as rare as what people would have thought 10 years back. So for me, my first patient was a rare patient that I had never seen. But now that if you go and have more awareness and really go looking for it, because nobody really looks for it unless kind of there is an awareness about it, it is not as uncommon. And we did a big study in Toronto and in big centers in the US for all high-grade gliomas using the proper MSI tool, which I will talk about a little bit as well, and found that the prevalence of all 0 to 40-year-old high-grade gliomas, RRD can be present in 5 to 12%. And even in the young adults, it is maybe 4 to 5%. And this is in North America. But there are countries in the world where there is high consanguinity because of the background of CMMRD being an autosomal recessive syndrome with a high prevalence in consanguineous families. We find very high prevalence among high-grade gliomas in children and young adults, as high as 50% in Jordan and 32% in Pakistan. But what about India? So this is an ongoing study that we are doing in collaboration with ASCO and many of our neuropathology colleagues. It is work in progress, but we already see trends that for IDH wild type high-grade gliomas between children and adulthood, so basically 0 to 40 years of age, 17% may be driven by replication repair deficiency. This is being led by one of our fellows, Dr. Duhita Sengupta, who is working very hard on this. And similarly for IDH mutant astrocytomas in the same age group, 0 to 40, but IDH mutant is more common in adolescents and young adults. So maybe more between 10 to 40. The prevalence is also 17%. So not as low as in North America, which is 5 to 10%, not as high maybe as in the Middle East and other countries with high consanguinity. But as you can see in multiple centers across India, the trends are the same. It is between, like some places there are high 25%, 23% in the south of the country, but many other places are at least between 11 to 16%. Even in AIMS Delhi, the study is published now, it is 16%. So it's not insignificant, and unless you look for it, you will not find it. And you need to look for it because of what I will talk about next. So the proper tool is important. And this is what I was talking about, logic. That is the tool that was used in this study and this study as well, where we look at the whole genome and the nature of the microsatellites and find these tumors as high microsatellite instability among high-grade gliomas. And similarly, in blood, these patients also have high microsatellite indel burden. So not only do we diagnose the tumors as RRD, but we also find out that whether it is from a biallelic context, which is CMMRD, where you have high MSI in the blood in normal patients without cancers, whereas others, including Lynch, where the germline is monoallelic or either not present, and other syndromes can happen, which can kind of mimic like neurofibromatosis. They will never have high genomic MSI in the blood. So we did a trial or a pilot study with our colleagues in Pakistan and found that even saliva, doing a buccal swab and sending it for logic helps us diagnose, because even the swab cells that we pick up are normal cells, not malignant cells, but they will have high MSI in CMMRD patients who have biallelic loss of mismatch repair function in all cells of their body. We also learned that as you become older, CMMRD is something that people have become aware about in North America and Europe and more in India and Asia as well. But what we don't diagnose that often is the young adults who are like adolescents and young adults with Lynch syndrome. Because as you become older, in childhood, it is more of CMMRD between 0 to 18. But now that you become like between 14 to 40, it is Lynch syndrome patients that have this biology and these gliomas. And these are unique Lynch syndrome patients who don't develop colon cancer in their 40s. So that is a paradigm that is well known, well established, very well kind of established in literature. But these are patients who, for some unknown reason, develop glioblastomas at age between 15 to 40. They don't have family history of colon cancers because their genotype is probably different from other Lynch patients. And now that we go looking for it in this age group, we find that majority are actually Lynch syndrome without any family history, without any of the classical stigmata of CMMRD like cafe au lait spots, but they have the same biology that we can do something about. So how do we manage RRD patients and what is the importance in our practical practice? So one is that patients with germline RRD, especially CMMRD, can develop many cancers. And sometimes they have, at least in 25% of patients in our data, two cancers that happen in the same time. Today, we will focus more on the brain tumor, specifically the high-grade gliomas. But whenever we treat this tumor or cancer, we have to make sure that there are no other cancers lurking elsewhere in the other parts of the body. Similarly, if you diagnose a patient with TLL and CMMRD due to a clinical phenotype or because it didn't have any of the fusions, you did sequencing and found hypermutation, you should also make sure that there is no brain tumor lurking there when you start to treat the T cell LL or other cancers. So this is an important part of a clinical practice of recognizing and diagnosing other tumors before they become manifest when you treat the first tumor which is presenting in front of you. The second importance is the importance of doing surveillance. So in CMMRD, the mutation keeps on accumulating. A random hit in a tumor suppressor gene or a oncogenic pathway can lead to the initiation of a tumor. And that then continues to accumulate more mutations and becomes more aggressive over time. So some of these tumors can start as low-grade tumors and then transform into high-grade tumors. So that is a different paradigm from what we see and train as pediatric oncologists, where usually cancers will present as cancers and not like the adult paradigm where polyps become cancers over time. But this is again different from pediatric oncology routine setup, because in these patients, this is what happens, that low-grade tumors transform over time and transform really fast over time, not like in decades, but like in months and years. So that is why if we do surveillance, when we diagnose a patient with CMMRD and find our low-grade tumor before it becomes transformed to high-grade, it's always advisable to resect it out, because then you don't allow the cancer to continue to accumulate mutations and become more aggressive and untreatable over time. So we did many studies over the past decade, and we found that even for aggressive brain tumors, if you diagnose them in the asymptomatic stage through surveillance rather than when they become symptomatic and come to you as malignant cancers, you can really impact their survival in a big way. And that is true across all cancer types. So this is another paradigm, that if you have a child with CMMRD, you should probably begin surveillance. And we updated that, I think, a couple of years back in this AACR paper. It is intensive, it is expensive, it's not always possible to do everything, but at least doing something. And we even showed in the previous paper that in LMIC, partial surveillance was better than no surveillance, which I forgot to put in one of the slides here. So surveillance for everything is the best. Partial surveillance is quite good, and no surveillance is worse. Similarly, when you are treating a patient with, let's say, glioblastoma with CMMRD, you treat the cancer, but don't forget about looking at the other sites and also continuously surveilling the other sites while you are treating the first tumor, because you need to kind of manage the other tumors before they become cancers in the other parts of the body. So this is again a practical message that we should continue to kind of remember, that treating TLL with CMMRD on maintenance, don't forget to do the brain scans, because there may be a glioma that is brewing there that needs to be resected out before it becomes a glioblastoma. So practical points are that RRD is not rare. CMMRD is common in children, but Lynch is becoming more and more common as we go looking for that. These cancers do give you some time before they kind of become more aggressive. So if you diagnose, look for them and surveillance them and take them out early, then you can really make a big impact in the survival of the patients. Because otherwise, as we probably know, CMMRD is a quite devastating and deadly syndrome where you basically get a cancer every 2 years on average, which we showed in another paper. So from that background, I want to talk about some of the practical stuff of how we are treating glioblastoma with this biology over the last 4 or 5 years, and share our experience so that we can learn from this and do things together and better in the future. So again, I will focus on the brain tumor part, and we will not discuss leukemia, lymphomas, and other solid tumors today. So focusing on RRD glioblastoma, I kind of told you how is it aggressive, how it continues to accumulate mutations and have MSI, which kinds of makes it more aggressive. So because temozolomide is a common drug used in glioblastoma, and temozolomide needs an intact mismatch repair system to work, the common regimen for glioblastoma does work in this patient. So radiation may hold it. Chemotherapy like temozolomide is like water for these patients. So the median progression-free survival is as low as 9 months, doesn't even reach that 12, 15-month boundary that we have for other high-grade gliomas. And at recurrence, in an era before immunotherapy came, it was like rapidly fatal. So everybody died after recurring within 2.5 months, and nobody was alive at 1 year. So of course, we needed to do something for these patients. And this is where learning of the biology and finding that they have hypermutation and high MSI and an immune-rich microenvironment was really important, because we could use immune checkpoint inhibitors. Just because we want to kind of revise in our mind what that means, a tumor cell is a bad cell. So the T cell, the immune system should logically take care of that. So they have wrong antigens which the T cells should recognize and eliminate in an ideal world. But that doesn't happen because there are many inhibitory signals that the tumor cells kind of make that kind of make the T cell not recognize the tumor cell, or even if it recognizes, not allows them to have the cytotoxic effect that we want. So one of these axes is the PD-1, PD-L1 axis. And immune checkpoint inhibitors, there are many destroying or working on many such axes. But the most common is to kind of use a PD-L1 or an anti-PD-1 to block this interaction, which unleashes the T cell to kill your tumor cells. And that can only happen if your tumor does have T cells around it. Otherwise, it doesn't happen, of course. So based on the fact that mismatch repair deficiency leads to hypermutation, high MSI, and an immune-rich microenvironment where your T cells are primed because there are so many mutations to identify and attack in a way, but there is that break that you saw. So this was a clinical trial that was done in North America and Europe and Australia 10 years back right now, or maybe like 5 years back right now, where we had only 10 patients, most of them with recurrent glioblastoma, as you can see with blue here, some with colon and other cancers. And for the first time, we saw that by using a drug called nivolumab, which is anti-PD-1, we had objective radiological responses as well as prolonged survival. You saw 0% survival at 1 year for recurrent glioblastoma. And here, all patients were at recurrence or progression. And you can see many are swimming more than 30 months. So this is like more than 3 years. This is how the survival curve looked like. And this kind of established that anti-PD-1, here nivolumab, is kind of the standard at progression for these patients. The beautiful thing that I learned from Uri and Eric is that pharma is always difficult to work with. They don't have an interest in LMIC. So how do we take that impact from the North American 10-patient trial to the world? So while that was happening, the trial, Eric and Uri decided to work with our pharma partners, work with physicians from across the globe through that network of IRRDC to treat many children across the globe together with the physicians with the same drug and the same protocol that was being used in a clinical trial. So this is what we saw, recurrent glioblastoma disappearing with treatment. This is actually my patient from home that I talked about before starting my talk. I was able to access nivolumab for that patient, and that patient showed this immune flare and then response and was alive for several years after that, ultimately passed away due to something else, which we'll talk about later. But we saw objective responses and patients who had two cancers. So the first patient who is swimming off for 4 years right now, or at that time rather, had metastatic colon cancer and glioblastoma. But both tumors responded because they had the same biology, and the 0% OS at 1 year became 3-year OS of 40%. And this is same for the 10-patient trial and a 45-patient initial experience. So this was the first time that we had something to offer that really worked in front of our eyes. And we were very happy, of course, about that because we could offer something to these poor patients who we didn't have anything to offer before. Since then, we have done or continued this work. The patient numbers have increased. Now we have more than 270 patients around the world treated with immune checkpoint inhibitor for this biology. So the question that often comes is that, do children and adults respond the same, and do CMMRD and Lynch respond the same? So that was a question because in adults, there is more common mismatch repair deficiency, which is drug-induced due to temozolomide, which I talked about in one of my previous slides. And there, because it is drug-induced, only some cells in the tumor get mismatch repair deficiency. So it's subclonal. Whereas when you come from this germline context of Lynch or CMMRD, every cell in your tumor has that defect. So in adults with acquired mismatch repair or replication repair deficiency, immune checkpoint inhibitor doesn't work for that long because there is subclonal evolution of the clones which don't have mismatch repair deficiency. But in children or adults CMRD or Lynch, every cell in the tumor has the defect, so they kind of respond equally. So everyone has this kind of 40% survival, which we will talk about how we are trying to make it better from 40 to even higher up in the last part of the talk. But it works in adults and Lynch if you have the biology that drives that phenomena. So we wanted to understand that 40%, so which are the patients where this tumor or rather this immune checkpoint inhibitor with anti-PD-1 monotherapy works. And makes logical sense, but it's still important to show that on like good experiments to kind of prove that if you have high mutation burden, high MSI burden, lot of CD8 cells, this brown dots, high PDL1 expression, brown stain here, then probably you are likely to respond the best because you have lot of neoantigens, you have lot of T cells. So basically removing the brake really works well. And patients who have all four, so high TMB, high MS indel, high CD8 and high PDL1 have as good as 80% outcome at recurrence with using a single drug. So even within these patients, not everyone is the same. That is what we learned in our initial paper. And if you have all four, then you have the best outcome. In real life, maybe some patients don't have all four. Maybe they have one or two, then the outcome is not that great, but on average, it's 40%. We also learned about this phenomena called tumor immune flare, which is a form of pseudoprogression. Because these tumors have so many T cells that are kind of primed to act around the tumor, you remove the brake and that T cell is now kind of unleashed to kill the tumor cells. And that leads to a lot of cytokine release locally, a lot of edema, a lot of inflammation. That was initially not known because that doesn't happen in adults because none of these adult GBMs are immune rich from the baseline. They were called as progression initially. And then we learned through these and other patients that if you continue to treat them, you can have second responses because the edema and the inflammation kind of settles. It's a closed space. So it's difficult to manage. And I can talk more about how we moved from steroids to now bevacizumab to manage this immune flare. But in no uncertain terms, we showed on patients and with the biology that this is an immune reaction. You can clearly see the CD8 T cells go up both on the RNA profile as well as on immune IHC, and lot of T cell clonotype receptors, so like active T cells which are actively identifying antigens coming up at what we call as immune flare before they kind of act and get the tumor and get rid of the tumor. So this is something we need to be practically aware of if we are managing such a patient. The other unique thing that we learned is that there is this pseudo progression which happens initially in the first 3 months, let's say, and then things respond if you have the good biomarkers. But there are some patients who continue to progress in the first 3 months of treatment beyond that, let's say 3 to 6 months. And again, we are humbled by these patients. This was one of the patients in the clinical trial while I joined here as a fellow. And we kind of sent that patient home to die because after 4 months, there was multifocal sustained progression. The patient had CMMRD, had a sibling who had CMMRD, and we were following up the sibling through our cancer genetics program. And 6 months later, we found when the sibling came for a visit, they come from the far north regions of Canada, that the sibling is okay, but also the primary patient is alive after 6 months of stopping treatment and going home to die. We called the patient back, we did an MRI and found that the tumors had disappeared despite being 6 months off nivolumab. So this was a great surprise. We were all happy the patient is actually still alive today. But what we learned from these patients is that you have this pseudo progression phenomena, but you also have true progression and delayed response. And continuation of immunotherapy and not getting frustrated by the initial lack of success should not hamper you if you have high TMB. This patient had a TMB in the range of 500 mutations per megabase. So had all the right biomarkers, but took time to respond. And the reason what we are finding is this. So you have a set of mutations that elicit an immune response, but we have no idea of whether that immune response is good enough for the cell kill that you need for the tumor. And these tumors kind of continue to accumulate the mutations as we treat them because the mismatch repair deficiency or a RRD process is always active in the background because it comes from a germline context. So the tumors evolve over time. So this is a patient, again, another patient who progressed after 3 months, had a biopsy, decompression of cyst, and the tumor actually was more aggressive, high mitotic index at progression, but also had a lot of T cells. And when we compare the mutational profile, both were high, 175 and 235. but they had evolved a lot over time. And when this patient was continued on immunotherapy, there is complete remission. And again, this patient is now alive after 7 years. So we learned that there are some tumors which have mutations which may not be the best ones to elicit an immune response, but because they continue to accumulate mutations, over time they can have the right mutations that have elicited the right immune response for the patient to respond over time. So being patient, if you have the right biomarkers, is important because you may have these surprises, which are pleasant surprises all the time, and patients who are like alive even now after 8-10 years of having their diagnosis of recurrent glioblastoma. But again, to be humble, it happens in 40% that we get responses, not everyone. There are the 60% that we need to work on. So what do we do next? So we found out that when we treat with anti-PD-1, there is compensatory upregulation of other checkpoints that are there on the tumor T-cell interaction pathway. One of them is CTLA4. So we found that you treat with anti-PD-1 and at recurrence or progression, your CTLA4 expression goes up. So the tumor is kind of mutating and finding its own way to survive. But if you track that and if you treat that with a drug called ipilimumab added to nivolumab when everyone progressed on nivolumab here, you have second responses and again patients swimming for more than 3-4 years. So you add a second drug and you get responses. But with this particular second drug combination, ipilimumab and nivolumab, we saw a lot of complications with autoimmunity. So it was toxic for our patients, and we did need to continue to look for newer kind of treatments to kind of make this more tolerable to our patients. Again, how the biology is important and how Uri's lab helps me decide what to use for my patients and patients across the globe is something like this. I know this is all too much to put in one slide, but we found in these tumors, thanks to Uri's team's research and our PhD students, like these tumors, though they are hypermutant aggressive, they have an addiction to the oncogene pathway, which is related to the RAS-MAP kinase pathway. So a lot of biology, preclinical studies to show that if you use MEK inhibitors, you can have these patients respond. And again, we took that to patients, and now we have a clinical trial running in the US with our group in collaboration that showed that MEK inhibitors can work in these patients because of the oncogene addiction to this pathway, and a combination of MEK inhibitor and checkpoint inhibitor is something that can work as well. So in summary, what I want to kind of say with all these slides is that anti-PD-1 is good, works with patients with biomarkers. We have to be patient, and we need more new forms of treatment for patients who don't respond to that strategy. With that, I want to talk about our new paper that came out earlier this year, because you saw we had 40%, and of course, there were some who were surviving with high TMB and high MSI and CD8 PDL1 at 80%. So of course, within RRD glioma, there is heterogeneity in response, and we wanted to find out if this heterogeneity could be linked to the biology. Again, the yin and yang and the marriage between biology and clinical service, what we do of how we benefit our patients. So you have mismatch repair deficiency in the background as a starting process in many of the tumors. And we hypothesize that you can have polymerase, and then you have a tumor group which is called prime MRD1, which have polymerase and mismatch repair. You have patients who don't get this polymerase hit, and you have a third group of patients who get IDH mutation and behave very differently. So we identified these three groups of RRD gliomas, which will be included in future WHO classifications, who behave very differently and need to be treated differently. So I will skim through the biology because there is levels of different types of hypermutation. So you can see that the mutation burden differs across the groups. So does the MSI burden. The mutational signature context differs because they have different signatures. Polymerase ones have polymerase signatures, the others don't. And the mutational profile is also very different. They all have P53 and ATRX, but the level of mutation goes down as you kind of don't have the polymerase and have IDH. But the more important learning point is that these tumors don't have the normal or the common pediatric glioma drivers like histone alterations, HTK27 and BRAF V600E. And we learned that that is because the mutations arise from a specific context of mismatch repair deficiency. And these mutations, the histone mutations in the V600E, are not linked to that signature context. So that's why they are either very rare or almost very absent in these patients. So these are different from the histone mutant gliomas and a completely different animal in a way. We also learned that in adult GBMs, they are mainly, or they are much more driven by copy number changes in addition to mutations. But in our tumors, because there are so many mutations, the mutations sometimes affects the same pathways that the chromosomal aberrations kind of lead to abnormalities for. So these tumors kind of use those pathways and they have less copy number changes and have more mutations which are driving the process. So we are also learning that they have different appearances on radiology. So the first subgroup has this cystic solid appearance. The second subgroup has this heterogeneous appearance, and the third subgroup has a diffuse infiltrative pattern. And there is also a link between how their germline etiologies may be slightly different. So patients with CMMRD are more likely to develop this first type of glioblastoma. Patients with Lynch syndrome are more likely to develop this third type of glioblastoma, and their location and which type of gene kind of is affected also differs. So there is a clear genotype, phenotype, and a clinical correlation between these three tumor subtypes. And in the paper, if somebody is interested, you can really go and see and read that how one type of gene mutation leads to one type of tumor versus others. As I talked about, there are signature contexts. So MMRD gliomas, though they accumulate so many mutations, their mutation accumulation is not random. These mutations arise in the context of specific signatures. And you can see here, V600E or G34R are not in the signature context of mismatch repair deficiency, whereas IDH132H can be because it's somewhere here. And even the P53 mutations are not random. They can have specific P53 mutations which are enriched because of the background signature that gives rise to those mutations. So the summary is that we also tracked which mutation appears first, which mutation appears later, through looking at the variant allele profiles. And we kind of summarized to say that these are unique group of gliomas, which are different from pediatric histone adult copy number driven gliomas. They have their own biology where there is first hit in the mismatch repair genes, then in specific P53 genes, and then it either accumulates polymerase and becomes subgroup 1, or stays subgroup 2, or gets an IDH mutation and becomes subgroup 3, and then continues to accumulate all the other mutations, which kind of depends on what is the background process and whether you have both mismatch and polymerase or only mismatch repair defect. Because of the burden of mismatch repair and polymerase proofreading defects in these tumors, the subgroups also have different immune microenvironment. So we found that the subgroup 1, which has the highest mutation burden with polymerase defect, have the highest tumor inflammation, whereas the middle group, which has mismatch repair, is somewhere in intermediate. And the IDH group is specifically important because IDH mutation leads to a metabolite called 2-hydroxybutyrate, nothing to do with mismatch repair or RRT. It's a general biological fact. And that 2-HGR2-hydroxybutyrate has an immune suppressive function. So on one hand, you have some hypermutation, but you have the IDH mutation, which suppresses an immune microenvironment. So these tumors have the least immune inflammation or immune CDTL T cell infiltration in the microenvironment. And this makes logical sense of how these tumors behave differently. So the first subgroup with one drug, anti-PD-1, nivolumab or pembro, has around 70% survival. The second subgroup has an intermediate survival, so initial responses and then progression. And the third subgroup, which has IDH mutation, doesn't really respond at all. So there is a clear reason of why we should identify these different subgroups, because we need to have that information of how they will behave with one drug. And the more important question of what we can do different for these two subgroups, who of course need something different than anti-PD-1 as monotherapy. So in the last few slides, I will talk about some of these new advances that we are learning and doing based on the data that we have, that there are 3 subgroups which probably need a different kind of approach for each one of them. So more precise approach than treating everyone who has RRD glioma with anti-PD-1 alone. So for the first subgroup, which had mismatch repair, polymerase, high TMB, high MSI, high CD8, and high PDL1, so all the good biomarkers, you saw that at recurrence, the experience of having anti-PD-1 was great. There were 80% survival. So we became ambitious because, as we know, these are young children with CMMRD who will get many tumors in their lifetime. We asked ourselves that if we have all these good biomarkers, whether we can avoid radiation, because anyway, it doesn't hold the disease and chemotherapy doesn't work. So we did a pilot study for 5 patients who had good resection, good biomarkers, and treated with them after surgery with anti-PD-1, and we found that all 5 were alive. One of them developed a second tumor and died because of that, but other 4 didn't have a recurrence of their initial tumor if they had all the right biomarkers. And now we have a clinical trial that pursues this strategy for this very small subgroup of patients of either avoiding, or if not avoiding, at least delaying radiation. So they get surgery, get on the drug after their biomarkers are kind of identified as good or excellent. Then they are on treatment. And if they progress again, they get a second surgery, get radiation, and continue on the drug. And we will see if that strategy is successful in the future. For the other patients who have not that great responses to anti-PD-1, again, we took those patients' cell lines, developed animal models, treated animals based on high expression of LAG3 in human tissues. LAG3 is another checkpoint that we wanted to target because targeting the CTLA4 didn't really work out because of the high toxicity, though we still need to use it for some patients. So from animal models, we found that for the second group who have an intermediate outcome, or rather initial response followed by progression, so lack of durability of response, we tested LAG3 and anti-PD-1 as a combination and found better responses than anti-PD-1 alone and prolonged survival, including 2 mice who didn't ever have recurrence of their tumors. So in humans, we had patients who had progressed after anti-PD-1, after 2 rounds of radiation, sometimes even getting CTLA4, and we had high LAG3 expression at progression, and we're able to treat this with this drug called Opdualag, which is how the pharma or one of the pharma makes this fixed dose combination of anti-PD-1 and anti-LAG3 and had radiological responses, prolonged survival. And this is again a clinical trial we are taking forward, at least in North America, Europe, and Australia, through a consortium called Connect, which is one of the largest brain tumor consortiums in North America. For the third subgroup who have this IDH mutation and the metabolite called 2-HG or 2-hydroxyglutarate that suppresses your immune system, again, preclinical studies in cell lines and mice to show that you can suppress the IDH effect, reduce the 2-HG level by using a drug called ivosidenib and now vorasidenib, which many of you may have heard while training in pediatric neuro-oncology or oncology, approved in adults, good results for IDH mutant gliomas in adults, which we now use in our patients, and find that for patients who have had progression on everything before, again, anti-PD-1, CTLA4, 2 rounds of radiation, but progressing thereafter, we add ivosidenib and have really remarkable responses because now you remove the 2-HG, you already have some hypermutation, and now your checkpoint inhibitor can do its magic or do its job, and we have prolonged survival. So today, we are treating these tumors according to their subgroup characteristics in 3 different ways. So the best subgroup gets anti-PD-1 alone without radiation. It comes later if needed. We have it open here. We have 2 patients enrolled, and this will open also in India and Jordan because, as we talked, the burden of disease is not insignificant there. We are starting with Tata Mumbai, but hopefully there will be other patients and other centers in the future. For the middle group, we are using Opdualag, so targeting anti-PD-1 and LAG3. And for the third subgroup, it is vorasidenib with Opdualag. The protocol is under review, and this is also a commitment that we will have this trial open in TMH and in Jordan, in addition to the traditional way clinical trials are done in high-income countries. So last 2 slides are about looking into the future in a way, because we talked about how these tumors mutate, evolve, and change their mind all the time while we are treating them. And while second biopsies are good and help us, as we saw that elevation of LAG3, elevation of CTLA4, you target those as second line or third line therapies, there are patients where we can't do biopsies all the time. So what is the solution? So we are using cerebrospinal fluid by doing lumbar puncture or by using Ommaya catheters to kind of track mutations, copy number changes which some of these tumors have, and also the germline, not the germline, the somatic MSI burden in form of MMRDNS, which is a quantifiable score. So you see this patient who responded and then kind of had progression and was ctDNA positive, and then was treated with anti-PD-1 and anti-LAG3, and the MMRDNS was not detectable, and the mutations disappeared over time. So this CSF ctDNA based analysis of response and also tracking early relapse or early progression before radiologically this becomes overt is helping us track these patients better, use minimal residual disease, the same concept in leukemia lymphoma from bone marrow, here from CSF, to see where we are. And we see that patients who clear their ctDNA earlier have a better survival than those who have delayed clearance of ctDNA. And this is becoming more and more routine practice, not only in this tumor type, but in medulloblastoma and other tumors. And there are papers that published by us from St. Jude's, from other group, that kind of show the benefit of using this as a strategy. The last point is that we are doing all of this quite late in the patient's journey. So surveillance, taking tumors out, but there is of course a tumor there, right? So what can we do in the future? We are still treating with radiation, surgery, chemotherapy, and the future is probably to intercept and treat tumors even before they become tumors or even before tumor initiation happens. So in this disorder, we have an opportunity because there is mutation accumulation over time. And we also now know that this tumor mutation burden, though these are high and variable, some have more high than others, the process that it arises from is not random. So they all have hypermutation, but we find enrichment of certain mutations across all gliomas, all colon cancers, which kind of gives us an opportunity to target these mutations, which will happen in the future, even before they happen. And that concept is by using preventative cancer vaccines before the patient has developed cancer, or therapeutic cancer vaccines as combination therapies once the patient has the cancer. So Uri is working with big shots across the world, including Dr. Drew Weissman, who got the Nobel Prize for the COVID vaccine. To take this, we are very encouraged with the initial data that we see in our preclinical model. It's not mature enough for a human trial, but when it becomes mature, we'll probably have patients with CMMRD who can get a vaccine before they develop a cancer. And if they develop a cancer, they can be treated with a vaccine with checkpoint inhibitor to kind of enrich the immune response. That is not the best one in all the subgroups that we talked about. So just coming to the conclusion, we kind of wanted to talk that RRD is a pan-cancer mechanism. So it's active in not only CMMRD, but Lynch, polymerase, other sporadic cases across different syndromes and across age ranges. So children to young adults. We need an appropriate assay to diagnose this cancer and syndrome. So we can't use the adult MSI panel and say this is an MSS cancer. We need to use the right tools to diagnose, otherwise we will miss the patients. Surveillance and early diagnosis is important because it improves survival. You pick up the tumors early and kind of catch them before they become very bad players. Immune-directed therapies have dramatically changed outcomes, as we saw, from 0 to 40%. And now that we have subgroup-specific precise strategies, maybe that will even improve more in the future. Understanding as trainees, we are trained on the clinical part of things, and often kind of, at least me, I was very afraid of kind of going into the biology because it was overwhelming. But now I see more and more, I don't need to understand everything, but with partnership with somebody who kind of works with you and tells you how that biology is important and impacts your patient care, you can actually do more. And for such syndromes and diagnosis, as you saw, a 10-patient trial is not sufficient to get drug approval or making it a standard of care, but a 40-patient trial is. So that's why we need to do things together to kind of advance the field, have drug access for patients in parts of the world where we would not have that, work with pharma to negotiate to make sure they are not afraid of doing clinical trials in LMIC in children. And that's how we think we will take the field forward. So again, this is not my work alone. The lab, a global consortium, funders who fund our work, and most importantly, the patients who we now see alive and happy, some in remission, many with chronic stable disease on drug. So again, I will stop here. Happy to take questions, and anytime we are happy to help through our consortium. If you have patients, if you have questions, always free to reach out to me either on my email, or if you have a patient, reach out to the group, and we will be able to do most of the things for free through the grants that we have, thanks to the support of all these donors. So thank you, and happy to take questions.
So thank you, Dr. Das, for such an excellent talk and sharing your expertise and breaking down such complex biological mechanism of mismatch repair defects. So we'll take few questions in from the chat box. So first question from Dr. Raj Warrior. What do you recommend to the sibling who carries the mutations?
So thank you, Dr. Warrior, for that question. So when we have a sibling who has CMMRD, we always put them on the surveillance protocol, the one that I showed you and that is published, because we have clearly shown that doing surveillance on a sibling who is having CMMRD allows us to catch tumors early and treat them better and improve their survival. For siblings who are, as a part of cascade testing, get a diagnosis of Lynch syndrome and not CMMRD because they have inherited one bad allele from one parent, they don't need any surveillance in childhood, and they go into the Lynch protocol surveillance when they become young adults.
Any role of ctDNA in surveillance apart from
So
imaging?
thank you for asking that. We are working on that. We are collecting serial blood, and where possible, where if a patient has developed a brain tumor and we are doing lumbar puncture for other reasons, we are doing that on both. So data is accumulating, but right now it's exploratory and not a recommendation.
Okay. So you discuss regarding the nivolumab treatment. So how long is the nivolumab continued in these patients? So the duration of the therapy.
So when we did the clinical trial, again, thank you for that question. The duration was 2 years. But when that 2 years came and we had patients who were alive, which we didn't expect, to be honest, initially, we were afraid to stop. So we continued, and we found that the longer you continue, your tumor, one may stay stable, but you can get other tumors that kind of escape that pathway. So we have this patients who have the third type of glioma, IDH mutant glioma, who are immune resistant, as I said, when you treat them with anti-PD-1. And the longer you treat, you also have a lot of immune adverse effects. So autoimmunity becomes a problem. So what we are doing right now is that if you have 2 years of remission on nivolumab or anti-PD-1, then we are using a weaning protocol where we use MRI and ctDNA serially to track over a year and kind of come down on the dose and space it out and then stop it. That gives us assurance that the disease is in remission. We reduce the risk of tumors that come up, which will be immune resistant, and also reduce the risk of autoimmunity. And we have a global protocol that we follow with physicians across the globe for this weaning of nivolumab after 2 years of remission.
Okay. So another question, will radiation increase the risk of second malignant neoplasm in these patients?
So great question. And this is something that comes up so commonly in our consortium from colleagues. This is not like Fanconi anemia. It's not like a DNA breakage syndrome that radiation will lead to more insult. It is an error of DNA replication. So radiation doesn't increase the risk of second malignancy more than what it does in a normal individual. So of course, radiation increases SMN risk for even normal patients, but CMMRD, RRD, Lynch, polymerase, radiation is effective because we saw that in patients, and it doesn't increase the risk of a second malignancy as compared to the general population.
Okay. So you discussed the diagnostic tool for this disorder. As in India, we have limited facilities. So are the tumor ISC marker for MSI is sufficient or reliable surrogate marker, or we need to add on apart from this tumor ISC?
So we will talk more when we have the data, but we know that IHC is very good, very cheap, but it is around 80 to 85% sensitive and specific. So we will miss patients, but IHC should be done in all such patients. I would go to the extent, and we have that as a recommendation in Ontario. Anybody who has a family history, cafe spots, of course, yes, but we would go to the extent of saying that maybe all pediatric high-grade gliomas, which are not DIPG and histone-driven, they should have the IHCs done because it's much more common than, let's say, G34R as a hemispheric tumor. So IHC is great, should be done for everybody who kind of is not DIPG in a way, but we need to do more. And we always talk about that we are LMIC, we can't do this, we can't do that. I am being a bit strong here. But logic, for example, everyone or like most patients today or most centers in India today have a sequencing machine. It's just like somebody needs the time and energy to use that sequencing data, work with the team here, and use that algorithm called logic, which can be then kind of used even in India. So that is the intent of what we want to work and kind of work together with everyone. And Uri works with many patients or groups in LMIC to have this translation of a tool which is inexpensive, which can be done in many parts of the world, but is not being done because of lack of awareness or kind of lack of time and interest. But money is not a barrier. Last point, in the pan-India study that we are doing, the criteria is that everyone who has IHC loss comes to us and we do sequencing, etc. But there are criteria of which patients have a higher risk. And we are finding that at least 5 to 10% of everyone who was that high risk by specific criteria had retained IHC locally, we are running logic here, and we are finding that 5 to 10% do have RRD. So summary, IHC, yes, but of course we should do more and we can do more.
Okay. So we discuss about nivolumab. Is there any different response with pembrolizumab if you use in that scenario?
So
Pembro?
our data is biased for Nivo just because we had more partnership and more engagement with BMS rather than Merck. We have some patients, and biologically they are supposed to be the same, exactly the same. But now we are learning that even anti-PD-1, they're all not the same. So many of you may be aware of the dostarlimab data in rectal cancer, 100% remission in mismatch repair rectal cancer in adults. That was not reported with Pembro or Nivo, though they are all anti-PD-1. So we know that even if they're anti-PD-1, each of these molecules may be slightly different. We have no reason to say that Pembro will not work, and that may be equally good. But our data and success is more biased for Nivo rather than for Pembro, just because we had BMS provide access in many parts of the world, which Merck was not interested in.
So is your treatment of choice depend upon which type of mutation out of these 4 common mutations?
So great question. In the mismatch repair system, there are 4 genes. So if you're asking that whether the treatment will differ based on which mutation is there in the germline, we don't have any data to suggest that, but we know that, which is there in our Lancet Oncology CMMRD paper, which I didn't allude to today or talk about today, that there are genotype phenotype differences between which gene is affected and what is the type of mutation. For example, a patient with PMS2 with a non non-frame shift or not stopping mutation, that patient presents later. Whereas somebody with a MLH1 mutation, which is truncating, so complete loss of protein expression, presents very young in childhood. So there is a genotype phenotype there. And we also have some association that the MSH2 and MSH6 may have a more higher risk of developing IDH mutant, so the third type of glioblastoma. So summary, we are still learning. There is genotype phenotype, but right now today it doesn't affect treatment. Once you have the glioblastoma, you divide it by subgroup independent of where the germline etiology is and treat them according to the subgroup and the biomarkers.
So these 4 marker you discuss, any scoring system based upon these marker?
So it is either present or absent.
Okay.
And the problem with IHC is that sometimes there can be like faint staining, some cells which are kind of retaining staining because it's technical, right? It's how you kind of do the staining process. So there is no kind of grading. For IHC, it's either loss or present. In contrast, for the MSI burden using logic, that is quantifiable. You can have MMRTness, which is more higher than lower. And we find that higher is more prognostic because, of course, that accumulates more errors, more immunogenicity, and more likely to respond.
So is there apart from glioblastoma, in which other brain tumor we should do these testing of CMMRT?
So I know we are running out of time and I can talk more, but we have other tumor types. So medulloblastoma is the second most common tumor in these children, but within all medulloblastoma, we don't know the prevalence. So I would not go to the extent of saying that you should kind of stain or treat medulloblastoma, but there is enrichment for SSH subgroup. So if you have an SSH subgroup medulloblastoma with or without P53, with clinical stigmata, family history, or consanguinity, I would strongly recommend you to kind of explore mismatch repair deficiency because we have SSH P53 mutant medulloblastoma in CMMRD, failing radiation and chemotherapy, and then responding to nivolumab. We have one ependymoma, and there are all these other tumors that can happen, solid and hematological, but each one is like kind of nuanced. So I don't have time to talk about them today. Sorry.
So there is no further questions. So again, thank you once again, Dr. Das, for such an excellent talk. So we'll connect you if we have any query regarding this disorder. And thanks once again.
Anytime, and thank you so much for having me. Have a good rest of the evening. Bye.
Thank you. Bye bye.